that good? Hello and welcome everyone to Practice Connect, CHN's regular educational event and networking event. Thanks very much for everyone coming out this evening. I know it's a busy time of year and we have busy lives working in primary care as well as in hospital systems and all around the ACT. So I really appreciate the time that you've taken to come out tonight. I'll start by our acknowledgement of country. I acknowledge the Ngunnawal people who are the traditional custodians of the land that we meet on today and pay my respects to elders, past, present and emerging. I recognise their ongoing contribution to our region and communities and their connection to land, water and culture. And I also acknowledge any Aboriginal and Torres Strait Islander people who are joining us tonight. So welcome to everyone. As far as the housekeeping is concerned, we have outside the ladies' toilets are down this hallway here. You can get out from that side or here. The men's are down that way. And there's a fire escapes down there. And obviously you can sprint down the stairs if you feel the need as well. First of all, my name's Jill O'Donnell. I'm the Health Pathways Manager at Capital Health Network. And this event's run in collaboration between the Quality Improvement Team and the Health Pathways team. And we have several members, just to introduce you tonight to the Health Pathways team are sitting across here and our people who run events. A Health Pathways team there, sorry, and the Quality Improvement team along here. We actually have a number of new staff members in the Quality Improvement team, and I'm sure you'll be seeing them around the traps quite soon in the new year. We've had a few new people join, including our Allied Health Engagement Officer as well, and Charlene from our Workplace Prioritisation Programme, which is also about GP placement. So we've got quite a few new members here tonight. So, and it's nice to see everyone else coming out to join us. So I suppose the first thing is, can I have a bit of a show of hands? Who feels comfortable about raising the possibility of dementia with their patients? I'm always aware of some of the discussions you hear about having good conversations and having conversations early. And I suppose it can be challenging for any health professionals to have the conversations and carers of people with who have a possibility of having a dementia diagnosis. It's often challenging to raise the subject. So being aware of our own discomfort can actually help us do our job better. If we're more aware of it, we can think about how we can do it well if the time came that we had to have one of those conversations. So tonight's event, I'll give you a rundown of how the evening event runs. So we're really excited to have you here. We've got a very important topic to discuss. Obviously, we've got 400,000 people living with dementia in Australia, and we undoubtedly come across them working in primary care and in the hospital system. Dementia is the leading cause of death in women and the second leading cause of death in men in Australia. And we need to consider how we contribute to making the journey of diagnosis right through to effective care and smooth and support as smooth as possible for our people that we're working with every day. And we also need to ensure that people living with dementia and their carers and family are linked into information and services when they need them, and the right services and when in a timely way. So tonight's event is all about helping us to better understand the patient journey for someone with a diagnosis of dementia and where we can help to support our local population in the ACT to navigate access and get information that they need, as well as services they'll benefit from, resulting in better patient care and better patient and care experiences and health outcomes. So we'll begin with a little update from Capital Health Network, and then we'll have our 4 speakers who are here tonight. I'll introduce them shortly. And following each speaker, there'll be an opportunity to ask questions. You're welcome to ask as we go along. And we'll have some questions at the end, and often there's more discussion at the end as well. And after the final speaker, we'll have dessert that will be served over there. You're welcome to help yourself to food anytime through the evening, because it's sitting there for anyone that would like some. And we'll catch up at the end and have a chance to network and meet more people around the place. So first of all, a bit of an update from CHN, from the team that we work in. The Quality Improvement team, first of all. CHN Quality Improvement team work with practices to understand how to use your data to support quality improvement. You might be familiar with the quick reviews that we send out to general practices, which provide data and ideas of how to use this for quality improvement. So it's about your own practice data that comes back to you. Please come and talk to the team, anyone in the team, if you if you have any questions about that over the evening. My Medicare is a big topic in our primary care world at the moment. It's a high priority right now, and we're encouraging practices who haven't yet registered to do so. So if you work in general practice and it hasn't been registered, please get in touch, and we can share guides about how to do that effectively, and how to access support if you need any support with doing that. As far as events are concerned at CHN this year, the last financial year, we've run 57 events, 16 face-to-face and 41 online. And that means we've connected with and provided education opportunities with over 6,000 people in the ACT. So you can see there's a lot of work going on as far as us trying to look at what the needs of the health workforce are in the ACT and how we can help to support everyone in the health workforce. So it's a pretty big achievement, and particularly thanks to the QI team and Canal, who's our events lead sitting over there, who does all the work that we don't all see. In the Health Pathways team, you may not know the Health Pathways team, which runs ACT and Southern New South Wales, which is Coordinator, the next door neighbour, PHN to CHN. We have a team that includes 8 clinical editors who are all local GPs and 2 clinical leads. They're all local GPs who work as GPs in the real world, as well as they're the people who write and update the pathways. And we work closely with the GPLU and the public hospital departments and specialists to localize and keep updating all these pathways. And we've been working recently on a dementia project, which is partly why this event came about. In the last 18 months, there's been a project going on focusing on understanding the local dementia support services through service mapping and developing resources for referrers, patients, and their carers. You'll see some posters on your tables. There's QR codes on those all around the room. This directs you to the patient and carer facing resources. These are resource books, which also sit on the CHN website. You can see it on our webpage. I've got all the local services available to patients and people caring with people with dementia. So get in touch if you'd like a printed version, but we're very aware of paper as well. So they're facing out towards patients and carers. So if you have a patient group that you would like them to have them, just get in touch and let us know. So now I'll introduce our first speaker, Dr. Morgan Sheridan. In his day job, Morgan is a GP working at Ochre Medical Centre at Gungahlin. He moonlights as a clinical editor with the Health Pathways team at CHN. And he's been helping update our suite, not just helping, but completely updating our suite of dementia-related pathways. And he's here today to talk about, look at the GP perspective when a patient comes into you that you suspect that might have cognitive impairment or dementia. Welcome, Morgan.
Thank you very much. Is that coming through all right for everybody? Great. So thank you very much for the introduction, Jill. As she said, I work as a GP and a clinical editor for Health Pathways. I've want to talk briefly about dementia in the GP context, but I also have some slides that kind of showcase Health Pathways for those of you who may not be familiar with it. I've kind of done 2 things. I've got a plan to try and actually go to the website for Health Pathways and show you how you log on, which will mean getting out of the slideshow and going to the actual, well, showing how you find it on Google and then how you log into it. If that doesn't work, the backup plan is just to show on the slides. So fingers crossed it does. But to start, I think most of us are familiar with working in a room sort of like this. And some of us are very specialized, but a lot of us see anybody and with any problem that walks through the door, at least initially, and then we've got to figure out, you know, the nature of the problem and then refer them on. So surgeons will do surgery, psychiatrists will do mental health. The emergency department will really only do emergencies, lots of other things as well, but they try and send those on to less acute services. Dentists, for instance, will do teeth, but GPs, by and large, tend to see lots of people for lots of things. And for a complicated condition like dementia, it means that you've got a lot to hold in your mind at all times. And that's very difficult. Dementia, it's a complicated illness. It's got many aspects to it, and it affects most aspects of patients' life as well. So just to go through some of the areas that you might be required to have some knowledge of as a general practitioner, you might have to have diagnosing it is the first step. There's a range of fairly complicated cognitive testing tools that you can use to do that. I don't know if you've ever had the experience as a health student, you're on a clinical attachment and someone hands you this Addenbrooke's cognitive exam and says, here, go give this test to somebody. They don't really explain how to do it. You go and you sit down and have like a 5-minute read through, and then you go and see the patient that you've got to administer the test to. And then you feel like you're the one who's being cognitively tested by having to apply it. And you look up, and of course, the supervising clinician has evaporated like morning dew, and you're like, well, okay, let's crack on. Apologies if we have to do this again tomorrow, because I don't actually know how to administer the Addenbrooke's cognitive examination. Then once you've made the diagnosis, you've actually got to communicate it to the patient. It's a fraught conversation. Nobody's happy to hear that they've got the possibility of mild cognitive impairment or dementia. Some people are really devastated by the news. Others are relatively sanguine about it. And then you've got to discuss the impacts of the condition as well. So most of your patients will drive. Most of them will not want to stop driving. It's not just because they've got a very nice car that they enjoy driving, but it's a loss of independence for them as well. Public transport in Canberra is much better than it is in many other parts of the world, but it's still got a way to go. So you can understand why patients aren't keen to transition to alternative modes of transport. And then there's managing the condition. Many of my patients, I feel that this is what their living rooms look like. I don't know if you can see in the picture, but behind that list of or pile of prescription medicines, there's also some non-prescribed bottles of supplements, vitamins, minerals, and other things. And it seems that nobody can remember exactly what they're on. When they come to you, it's a condition that affects memory as well. That doesn't help. And then if the patients have been seeing you for a long time, they often have a list of sort of zombie medications that haven't been crossed off the clinical records, and it takes a bit of time to tidy up. My point here is it's impossible to hold all of these aspects of dementia care in your head at one time. And this is where clinical guidelines come in. So I'm just going to see if I can pause this. Maybe if I minimize it. No, that's just going to keep the presentation up. That's good. So if you go to Google and then you type in health pathways, ACT, it's just the landing page. And then what it would take you to is this first page. 2 ways to navigate the Health Pathways website. The first is the obvious one. There's a search bar up the top. So if you just type your search bar in, for example, dementia, you'll see that there are 85 pages at the time that this screenshot was taken that mentioned dementia. And then you can just scroll through the list, or you can add another search term if you want to narrow it down to say dementia and driving, something like that. The other way is there's a sidebar that has a topic menu, which is this one just here. So if you scroll down that sidebar, you'll see a list of topics. There's one called Older Adults Health, and then most of the main topic pages that are to do with dementia, you'll be able to find just there. So this is a mid-presentation recap slide. If you need to find Health Pathways, just Google Health Pathways ACT. That is the URL for those of you who prefer to use URLs, and that's the generic login and password. When you go into one of the pages, it will have an assessment section, a management section, and a referral section. So whether you're looking for something to do with, cognitive examinations, you're wondering who to refer to, or you're wondering something about, medications for dementia, it'll have a section there that you'll be able to consult. They are rather large and encyclopedic pages at times. We try and keep them brief, but unfortunately, dementia is complicated. And is really several sub-conditions rather than just one condition, which means that I'm just going to skip ahead and come back to it. If you're looking for a particular term in the page, there's the Control F click, Control F trick. So if you press Control F, it'll bring up a search box and say you want to look for driving. You just type driving into it and it'll find all the mentions of driving within the page. So that's a quick trick that you can know to navigate the page. In the topic sidebar, let's just go back here. You'll notice that some of the topics are listed in black and some of them are listed in gray. All those pages exist. The black ones are the ones that we've been able to review. The gray ones are still correct information, but they're yet to be localized for the Canberra, South New South Wales context. So, for example, we haven't yet managed to localize the delirium page. So we have borrowed another region's page. So all of the information in here should be correct and up to date for managing delirium, but Health Pathways is a New Zealand invention. So this page will say, it might reference it might reference services that aren't available in Canberra. It will say, please refer patients that are critically unwell to Canterbury ED, for instance. Obviously, please don't send patients who are critically unwell to Canterbury ED. Just to finish up, at the bottom of every page, there is a feedback button. If you click on that, it will bring up a little form, and you can use that if you find a mistake in the page. We'd love to hear about it. If you find something missing in the page, we'd love to hear about it. And if you can't find a page at all, we'd also love to hear about it. So we do keep information on who visits or how many visits a particular page gets. So, for instance, we know that the COVID page gets an awful lot of visits. We try to keep that one updated regularly. The eating disorder page is also one that tends to get quite a lot of visits, so we try and keep that up to date regularly. There is a problem with this. If we don't have a page for it, you can't visit it. So if you want to tell us that you'd really love to visit a page on whatever condition you can think of, but you can't because it doesn't exist, which is a problem, just click on the send feedback button. It's quite responsive. You will actually get an email back confirming that your message has been received, and we're pretty good about following it up with you quickly and letting you know what our plans are for fixing that. Thank you very much. Are there any questions?
Good. Thank you. Thanks, Morgan. So our next speaker is Donna Bainbridge. Donna is a social worker at the Fisher Family Practice on the south side of Canberra. Donna started working with older people in the first Commonwealth aged care packages in the northern suburbs of Adelaide in 1995. Following this, she worked in aged care facilities, coordinating volunteers and lifestyle programs while completing her Bachelor's of Social Work. And then she gained a position as a social worker across the Lyell, McEwen and Modbury hospitals in South Australia. In 2021, Donna moved to a position with Uniting Communities Specialist Elder Abuse Unit. And she had a lot of background in that area. And today she's a social worker at the Fisher Family Practice as part of Capital Health Network's Social Workers in General Practice pilot program. Welcome, Donna.
Thank you. Oh, just be careful. I have only one slide. I get distracted and I've got a lot of talking that I'd like to do. So this is a really different project, having social workers embedded in GP practice. And it comes from, I think, the burnout that GPs have experienced COVID. So when I receive a referral from the doctor and when the patient has an appointment with me, I ask myself the following. Roles. Who is this person in front of me? And what role have they had in their life? Rituals. Each family is different, and I'm looking for patterns and how important rituals are to the patient. Religion. What is important? Spirituality. What is important? Culture. This encompasses your belief, social groups, and behaviours. Ethnicity. Some ethnic groups are very distinct. However, there may be some crossover with cultural groups. Gender. A person's own sense of identification as male or female and not limiting patients who identify as non-binary or transgender. Gender expression. The way in which a person externally expresses their gender. Diversity, the differing elements of who we are, keeping in mind that diversity is a variety of aspects that make up who we are. I am always mindful and aim not to use jargon, and during the appointment with the patient and the family or friend, I will discuss community, work, family, and social connections. So where do I start as a social worker? I always look at protective measures, and they are enduring power of attorney, advanced care directives, giving emphasis that they are your voice for legal documents. I do ask patients if they have a will, and I do ask if patients have reviewed these documents regularly. I also discuss formal and informal support networks, and I refer to them as wraparound, explaining that both are very important. So for example, a formal, I might talk about My Aged Care. I will talk about Carers ACT and Dementia Care Australia. So informal, I will talk about family, friends, social work groups, at community and work. The first appointment is a time for patients to process the diagnosis, and I encourage return appointments to discuss forward planning and pathways. I also encourage patients to contact me one-to-one if they need to understand or express themselves about the diagnosis of dementia, or if anything I've talked about is not clear to them. So I've got two case studies that I briefly want to talk to you about and just explain how very different they are. So the first one was, these are referrals from the doctor. Patient early diagnosis is very hard of hearing. Partner is legally blind. The outcome, they will think about the referral pathways that I discussed, but for them, moving into a retirement village from a very supportive community has them socially isolated. So the support that I provided to them was linking them into their community. So the second case study was partner came in as a suggestion from the doctor. Partner spoke about diagnosis and other presenting issues that were his concern about his partner. So I discussed My Aged Care, enduring power of attorney, advanced care directives, Centrelink for carers payment, and counselling for him. I spoke about the MOOC course from the University of Tasmania. I spoke about social supports for both him and her, and counselling for him. They have both came back in, and I discussed with her the impact of the diagnosis of dementia. I discussed, were their friends aware? I discussed patterns. and I discussed routines, and we discussed advanced care directives as her voice. We discussed reminiscing, and we discussed foundation memories and how they are very important for a person that has a diagnosis of dementia. Thank you very much. Is there any questions?
Program that you mentioned from Tasmania Union.
So it's an online one. I did it in about 2017, and then I continued and have qualifications in dementia care. It's pitched at just making it easier for you to understand the diagnosis, and talks about wraparounds in the community. So it's for everyone to do. It's a 6-week program. University of Tasmania has huge research on dementia, and quite a lot of supporting evidence comes out of the University of Tasmania. It's MOOC, MOOC. So if you just put the University of Tasmania in and then put in dementia, that should come up. So yeah, it's only an hour of your time at night, so it's not arduous to do. A lot of pictorial stuff, and so easy for you. So they might put a scenario up, and then you have to drag and drop to what you think, and they'll tell you the outcome for that.
Donna, can I ask out of interest, when people come back and you say, have you told your friends, is that something that's an issue for many people? Do they not come out and tell their friends? Do people try and keep it as a private thing?
I think what I try to explore is not only the impact of having to tell your friends, but then my thinking is always, how much do you want to expose yourself to what's going to occur for you? And I also will talk about strategies, about how you talk about that and who you talk to about that, because some people are just casual and some people will get it and understand what you're going through. I found my experiences, people are very different in how they want to present or talk about that diagnosis, and are quite wary, because my experiences is that's fractured relationships, because the other person they've been friends with, it's they can't cope with that. So I'm really mindful about how they tell their friends, when they tell their friends, and then how they present that. So the example I want to give you, person just recently said, I just keep saying I've lost my marbles. So I wanted to know how comfortable she was saying that. And that's how that fitted her at that particular time. Yeah, sorry.
Is the support relationship with you ongoing, or
yes,
are you referring to other services?
No, and that's an interesting question. So it's an ongoing relationship, and I have discussed, one person that's come straight into my mind, I've discussed referring on, and they don't want to. So they are aware that they're having impairments, but they want to come back to me. So our sessions are now, as much as I want to refer on to support or services that are very much more skilled than maybe what I am, this person wants to stay coming back to me because there's this trust and being comfortable. So now we're talking about strategies for, for example, where do you put your keys? Put them in the same spot. Are your family aware of where you might put your keys? So talking about strategies that build on that foundation, to keep them at home.
And we always hear about people not wanting to talk about enduring power of attorney and that sort of thing. What sort of reception are you getting from people in these conversations? I
think my framework comes from working in an elder abuse unit. Always my radar is that. And I talk about enduring power of attorney and particularly advanced care directives. So most people will go, I'm not going to be for resus, I'm having it tattooed, I'll have a sign put on me somewhere. But then my conversation is around, it's your voice. It's a legal document. And if you're in hospital and you like your makeup on, for example, and that's not being flippant, I've had people say, you write that in that document. If you don't want to go to ED and you want to contact your specialist who might get you a direct admission into hospital, put that in that document. very, very important. Enduring power of attorney, again, I speak about that. And who are you secure with your substitute decision maker? Because when they need to use that document, that's really important. And then that helps them as well. And I'm talking about finances and, you know, making those sort of decisions for people.
Do we have any more questions for Donna? No. Thank you very much, Donna. Now, our third speaker this evening is Rachael Mitterfellner. Rachael's been working as an occupational therapist with Canberra Health Services for just over 4 years. Rachael's worked in rotational positions, including older persons rehab, community care, inpatient and outpatient rehab, and acute care. Currently, she's working in an inpatient setting at the University of Canberra Hospital, where she's helping run the post-diagnostic dementia support program called SPICE, which stands for Sustainable Personalised Intervention for Cognition, Care and Engagement. As part of this program, Rachael delivers the care of people with dementia in their environments, or the COPE program that you may have heard of, and cognitive stimulation therapy to people with dementia and their caregivers living in the community. Welcome, Rachael.
So firstly, so today I'm going to be using the SPICE program as a case study for post-diagnostics, evidence-based post-diagnostic support, and talking a bit about dementia in the ACT, the role of occupational therapy, and also going through a case study and some additional resources and supports. Post-diagnostic support is the process of continuing care and assistance for both persons with dementia and their carers. Research by Western Sydney University indicates that post-diagnostic support needs change over the course of dementia, with a high level of care and need at the point of diagnosis, when the person with dementia is needing formal care or needing to transition into full-time care. This research also found carers desire practical strategies and information to support them in their caring role for the person with dementia. An estimated 6,600 people are living with dementia in the ACT. And as Jill stated earlier, it is the second leading cause of death in Australia and has been the leading cause of death in women since 2016. An estimated 35% of people with dementia in Australia live in residential aged care. However, in the ACT, only 25% of people with dementia are living in residential aged care, and there is a disproportionate number of referrals to Dementia Support Australia. The SPICE program was designed by Canberra Health Services in collaboration with the University of Canberra to address an identified gap in post-diagnostic support for people with dementia and their carers in the ACT. The program was refined through public consultation with Dementia Australia advocates and staff, and first launched in September 2022. Shown above are some of the UC and Canberra Health Services staff involved in the SPICE program, most notably research lead Nathan de Cunha, who is here tonight. As Jill stated, SPICE stands for Sustainable Personalised Interventions for Cognition, Care and Engagement. The SPICE program is a comprehensive multidisciplinary post-diagnostic support program that combines individual and small group components into an intensive 12-week intervention. The program has 5 evidence-based components. These are dietary assessment and advice, cognitive stimulation therapy, physical activity, care education and support and capacity building, and the care of people with dementia in their environments program. I will now go through each of these components in turn. People with dementia are at risk of undernutrition and weight loss, with 20 to 45% of people with dementia experiencing clinically significant weight loss. Maintaining adequate nutrition is critical for maximising health and quality of life in people with dementia and reducing the risk of functional decline, falls, pressure injuries and infection. All SPICE program participants receive 3 nutrition consultations with the UC health clinics, in which they are provided with advice on how to optimise the person with dementia's diet and nutritional intake. During SPICE, people with dementia also receive group cognitive stimulation therapy twice weekly. Cognitive stimulation therapy adopts a strengths-based approach and aims to engage participants in stimulating and enjoyable group activities, reminiscence, discussion, and social interaction within an optimal learning environment. Whoops. CST is the only non-pharmacological intervention recommended for dementia in the UK NICE guidelines, and research indicates that it improves cognition, communication, and social interaction in people with dementia. As you can see in this slide, each cognitive stimulation therapy session follows a structured format with a different theme for the main activity. These are some examples of the different cognitive stimulation therapy session topics. Some examples are current affairs. In the current group, we discussed the voice referendum, and in some groups, we've discussed voluntary assisted dying. Another session topic is using money, where participants discuss the change from pounds, shillings and pence to dollars and cents, as well as new payment methods today. There is also a session on occupations, and we tailor this to participants by discussing their occupations and how their roles have changed today. Exercise is protective against progression of early stage dementia and is of the greatest benefit if incorporated into the lifestyle. Research also indicates that exercise can be more beneficial if implemented in the group setting. During SPICE, the people with dementia and their carers take part in a physiotherapist-led, circuit-based group exercise program twice a week that is tailored to their capabilities. The exercises target balance, upper and lower limb strength, dual tasking, bone health, aerobic fitness, and falls risk reduction. The exercises at each station are designed for the carer and the person with dementia to complete together. Even though they may be doing exercises at different levels of difficulty, they are still working together as a pair, with the carer recording the number of repetitions, sets, and difficulty level. Not only does this support the person with dementia's participation, but the carers also benefit from having 2 afternoons a week set aside to complete their own rehab, which they often do not have the ability to do due to their caring responsibilities. During SPICE, the carers also attend a weekly psychoeducation session with a variety of clinicians to provide practical information about caring for a person with dementia, including sessions on communication skills, positive behaviour management, environmental considerations, the impact of medications, and care wellness, self-care, and stress reduction strategies. Finally, the care of people with dementia in their environments, or COPE program, is embedded within the SPICE program. This program includes 8 to 10 home visit sessions with a COPE-trained occupational therapist, comprising of comprehensive assessment of the person with dementia, their caregiver, and the home environment. COPE is a practical program in which the occupational therapist works collaboratively with the person with dementia and their carer to help the person manage daily activities, remain active and independent, and to help the carer support the person to live at home for as long as possible. This is achieved by identifying the person with dementia's strengths and challenges in performing everyday activities and providing carer training and strategies for effective communication, behaviour management, and setting up activities and the environment to increase the person's engagement. Strategies and activities are tailored to the abilities, interests, background, and routines of the person living with dementia and their carer. The therapeutic benefits of the COPE program have been shown to be greater than the effects of some medications, and it has been shown to result in significant improvements in the person with dementia's engagement in activities and to delay functional decline and nursing home placement. It has also been shown to improve quality of life in people with dementia and to reduce carer stress, with these effects maintained up to 9 months after the program. The clinical practice guidelines for people with dementia recommend that people with dementia living in the community receive occupational therapy interventions, including tailored intervention to promote their independence and participation in activities of daily living, individualised carer support, education and skills training, environmental assessment and prescription of modifications or assistive technology to minimise the impacts of dementia on safety and daily living, social connection and strategies to promote optimal mobility, continence and nutrition. And it is also recommended that family and significant others should have access to services which offer ongoing education and support. So as you can see from this slide, occupational therapists adopt a variety of strategies to assist people with dementia and their carers to help the person continue living in the community, maintain independence and safety, and engagement in activities, as well as social participation. Up to 90% of individuals living with dementia will experience some form of behavioural and psychological symptoms of dementia. Changes to a person's memory, ability to make decisions, initiate, organise and perform daily activities is a common presentation for someone with dementia. Increasing difficulties with performing everyday activities such as personal care, household tasks, previously enjoyed hobbies, interests and social activities can contribute to a person with dementia experiencing boredom, frustration, restlessness, agitation, depression or other symptoms, as previously valued activities and roles become more difficult to engage in. Being involved in meaningful activities provides a sense of meaning and purpose, helps promote personal autonomy and positive feelings, and is critical to maintaining well-being and quality of life for people with dementia. Meaningful activities can also assist with preventing and managing the behavioural and psychological symptoms of dementia associated with boredom, loneliness, and agitation when the person is unable to engage in activities in the same ways they did previously. Occupational therapists can work collaboratively with a person with dementia and their family or carers to identify strategies and solutions to compensate for these cognitive changes and support the person to participate in activities that are tailored to their needs, strengths, abilities, interests, and preferences. Dementia can also impact a person's ability to make judgments concerning their own safety and ability to understand the meaning of objects and situations, which can increase the risk of accidents occurring. People with dementia can experience their world as confusing, disorientating, and at worst, disabling and even dangerous. As function deteriorates, a person with dementia might need their environment altered to allow them to safely navigate and use the space, and to support them to participate as safely and independently as possible in meaningful activities. In the same way that physical ramps and other measures can support people with physical disabilities to access their home and community, a well set up environment planned with impaired thinking skills in mind can help maintain abilities and provide meaningful engagement, essential prompts, accessibility, and reduce risks for a person with dementia. An occupational therapist can provide tailored advice about adaptations to the home to make it more dementia-friendly, enabling, and safe, like increased lighting along passageways to facilitate safe night access to toilets. People with dementia may also experience changes in their vision and may lose the ability to perceive and understand depth, which can lead to difficulties negotiating steps and stairs safely. Installing high contrast tape or grab rails can increase awareness of changes in height and support visibility. People with dementia may not always anticipate and avoid unsafe conditions, so it's important to identify and eliminate trip and slip hazards, such as electrical cords, broken tiles, uneven surfaces, or raised floor coverings. Loose rugs and mats should be removed or secured to the floor using double-sided tape or underlay. Occupational therapists can also recommend grab rails be installed in bathrooms to support the person's functional mobility and balance and reduce the risk of falls. And small changes like a handheld shower head can make it easier for the person to complete showering tasks while sitting and can also make assisting with showering easier. Toilet doors can be re-swung to open outwards to prevent the person from becoming stuck in the toilet, or in some cases, lift-off hinges can be installed, which enable the door to be lifted off to access the person. And shown on the screen here is a portable door alarm, and that can alert carers if a person with dementia wanders outside at night and can be taken on trips away if the person becomes more disorientated at night or in an unfamiliar environment. Environmental adaptations can also support the person with dementia's participation and safety by compensating for cognitive deficits. Strategies such as calendars, diaries, alarms, and building daily routines can help a person with dementia to participate in important daily activities. An orientation board, whiteboard, or large calendar or diary can be used to orientate the person to their daily or weekly activities and routine, and can be used to write lists, reminders, and important messages. A clock, which clearly displays the time, day, and date on a large face or in bold numbers, can also assist with orientation. Signage or colour coding of the environment can also be used to orient the person to their environment, such as labelling hot and cold taps or installing a contrasting colour toilet seat. Objects which are out of sight in cupboards or with solid doors do not offer a visual prompt. Placing commonly used items in a consistent and visible location, labelling cupboards and drawers, or placing items in transparent containers can make it easier for the person with dementia to locate items and participate in daily activities. An important caveat of all this is that the general rule is to change as little as possible in order to maintain familiarity, as big changes to the environment can cause distress and confusion. This may involve keeping a cherished personal possession or replacing appliances and other items with a similar model that looks and operates in the same way. For example, if possible, a kettle or toaster should be replaced with one that looks similar, because this can facilitate the person with dementia's ongoing independence with preparing their own breakfast or a cup of tea. I often recommend that a person with dementia and their family set up a personal alarm with GPS tracking. This can provide the person with dementia and their family with peace of mind by enabling the person to access timely assistance in the case of a fall, becoming lost, or other emergency. There are also very basic mobile phones like the Kaiser phone, designed for people who have cognitive impairments or low vision, which have inbuilt GPS tracking. It can be beneficial to think about introducing a personal alarm or mobile device early to enable the person with dementia to become accustomed to wearing and using the device. As an OT, I also regularly administer standardized assessments to assess client cognition and use these in combination with functional assessments to determine the impacts upon the performance of everyday activities. Some strategies that can assist when completing a cognitive assessment with a person with dementia are to reduce distractions and provide a quiet environment. Explaining the purpose of the assessment in simple terms. I often say to someone, I'm going to ask you today some questions that look at your thinking and memory. Take a few moments to put the person at ease by asking about their weekend, family, or hobbies before jumping into the assessment. Provide reassurance and encourage the person to do their best. The person may need additional prompts and encouragement to initiate and attempt all assessment tasks. Position yourself facing the person, maintain eye contact, and remain in the person's line of vision when talking. Repeat or rephrase questions or instructions to ensure the person's understanding. And if appropriate, you might use facial expressions, gestures, and visual and physical prompts, such as having the person point to answers or placing a pen in their hand to encourage participation in writing or drawing tasks. Allow additional time for the person with dementia to respond to you, to allow time for processing, and accept their reality. Avoid correcting false beliefs or ideas, as this can lead to agitation or distress. If the person does become upset, maintain a calm, easygoing manner, provide reassurance, and distract or redirect by going for a walk, visiting the bathroom, getting a drink, or changing the conversation to a pleasant topic before returning to the assessment. If a person is still very upset, it can be good to consider reattempting the assessment at another time if possible, and ensure hearing aids and glasses are used. Now I'll run through a quick case study. I worked with a person with dementia and their carer, where the person with dementia was waking up and wandering at night, becoming distressed, attempting to leave home, and this was disrupting the client and carer's sleep. The client and carer's goals were to reduce the frequency of the client waking up and wandering at night, for the client and carer to feel more rested, and for the client to engage in more meaningful activities throughout the day. Strategies were brainstormed collaboratively with the carer and the person with dementia where possible. The strategy centered around communication included the carer providing simple instructions, reassurance and redirection, remaining calm and validating the client's feelings. Environmental strategies included the use of written and visual prompts to remind the client that it was nighttime, and to assist with locating the toilet overnight, locking the front door, removing unsafe items from the kitchen, and having a glass of water at the client's bedside. We also ensured that the bedroom environment was conducive to sleep. Other strategies focused on establishing a familiar and predictable bedtime routine, limiting food and drink before bed, setting up a bathroom regime, reducing daytime napping, and providing stimulating activities during the day, including opportunities for physical activity and being outside. At the end of the program, there was a significant reduction in the person with dementia waking up and wandering at night, and a reduced level of carer upset and difficulty in managing this problem. The carer reported a high level of confidence implementing the strategies and increased confidence engaging the person with dementia in meaningful activities and reducing their agitation and distress. This is a diamond dot artwork that was gifted to us by a SPICE participant with Parkinson's and Lewy body dementia. The client had stopped making art, but was able to participate in this activity once the carer had set up the activity, placed the coloured dots in labelled containers, and built up the stylus that they use with a pencil grip to make it easier for them to hold and manipulate. And as was mentioned earlier, driving is a complex task that requires attention, memory, judgment, and the ability to plan. As per the 2022 OST-ROADS guidelines, all drivers in Australia with a condition which may impact on their ability to drive are legally obliged to inform the driver licensing authority. And this includes people living with dementia. Most adults, however, are unaware of this obligation. Regular review, at least every 6 to 12 months, of safe driving capacity is recommended in patients who retain a driving licence early in dementia. Now I'll just go through some resources. This book is written by the occupational therapist who designed the COPE program and provides practical information about dementia, how to use activities, manage challenging behaviours, how to reduce carer stress, as well as environmental and communication strategies. And I'm just going to flick through these slides, which list some additional resources and supports that are available for people with dementia and their carers in the ACT. And those are the references.
Thank you very much, Rachel. Does anyone have questions? No one at the moment? Thank you very much. That was great.
Oh yeah, let me put that up. Sorry.
So our final speaker tonight is Ivy Huang. Ivy is an enthusiastic clinical nurse educator at Canberra Health Service. She's based in an acute geriatric ward with a postgraduate education in aged care nursing. She's currently leading the cognitive impairment project across 3 hospitals, including Canberra Hospital, University of Canberra Hospital, and North Canberra Hospital. Her expertise lies in providing education and training to support healthcare professionals, including medical team, nursing team, and allied health team, and in timely identification and management of cognitive impairment, encompassing both delirium and dementia care. Welcome, Ivy.
Thank you. Oh, this is the second page. So thank you for having me today. And today, before we start talking about dementia care, I would like to ask you a question. When I mention dementia, what's the first word pop up in your mind? Yes? Elderly, yeah. Anything else? Memory, yes. Anything else for dementia? Loss. So we can know it's all like sad word. And why I want to mention this is because the information about the elderly. I think a lot of times we do think about dementia for old people only. So when I first started rolling out this project, I got a problem. Some educator tell me like, Ivy, I don't need a dementia care. Just teach us delirium. Why? oh, we have geriatric ward. Nurses there can handle dementia. We are fine. Is this true? Is dementia for all people only? I don't think so. So as we know about Jill mentioned already, yes, age is a high risk for the dementia. We do have 1 in 10 Australian people are having dementia when they are older than 65 years old. It's also a leading cause of death in dementia for the male and female. But what happened to those people who got dementia when they are under 65 years old? How do we call it? Younger onset of dementia. And how many people are having it? Over 30,000 people already. What happened to them? So when I was giving the education at Canberra Health, there was once after the training, a nurse came to me and she shared her story with me, which kind of broke my heart. Her husband was 47 last year, and he became quite confused for a while with memory loss. One night, he woke up and had a fall. She had to take him to a hospital. He's been waiting 6 hours in the ED. Finally, someone saw him. They said, oh, well, your blood looks fine. We don't think you have infection. But yeah, he looks confused. We're going to give some antibiotics. Observation overnight, and then send him home next day. Because they couldn't find anything wrong with him. And he's only 47. What can we do with that? After another month, the situation goes down. Condition is not improving. She took her husband again to the hospital. This time, perfect. They actually do a good investigation, and they find he has dementia. How can she feel in this stage? She's a nurse. She works in the hospital. And she's like, I tell you, my husband is not my husband anymore. He's confused. Why no one do anything more? It's just because he's not old enough. So I want the people to start thinking about when a person comes to you and shows confusion, we need to start thinking what else could happen. Especially we also have childhood dementia at the moment. We have more than 2,000 kids have dementia. And their lifespan is only 5 to 7 years as well. So we want to start thinking about dementia is for every age. We need to do more assessment at an early stage. And as we know, 400,000 people have dementia by this year. What happened after another 30 years? We estimate the number will go double. So how can we handle that in the next few years? We are not even starting dementia training yet. But when the number go above 800,000, what can we do? So that's why I take action now. And that's why I'm here today. Thank you for having me. So when the patient have a dementia diagnosis, family first question is like, I think, so why? Why is he having dementia? Am I gonna have dementia? What's the risk factors? So these are the factors can contribute to dementia, but they are not 100%. But of course, we want to encourage people to eat well, keep your physically fit, and make sure you don't expose yourself to the secondhand smoke, you control your hypertension or diabetes well. But family, they want to know more. They want to know, am I 30% chance to have dementia? Is my kid might have dementia 50% because genetic issues? I was like, I'm not sure. It's really hard to say. It's case by case. So I found a really good tool I want to share with you. This is self-exam tool. It only takes 20 minutes for everyone to do it by yourself. They'll ask you about your diet, your physical history, medication history, and everything. In the end, this is evidence-based, including international and national evidence-based. They will let you know what's your risk score and what kind of recommendation they're going to suggest to you. This is also very good documentations you can bring to a GP and to discuss with your GP in the future. Okay. So please share with your family or your residents, your patient's family. So as Rachael mentioned, we do have a lot of patients in the community. We really try to use a spice to keep them in the community. But while they are still in the hospital, 2/3 of patients with dementia are in the community, but what happened to another 31%? So what's the common reason you think to bring them to the hospital? False, yes, false. Anything else? False is so common, yeah? Infections, thank you. So yes, so there are so many reasons why they are here. The main reason for dementia patients to come is because they have DPSD, which we call challenging behaviors, agitation, aggression, those things. Sadly, 90% of them in the end stage of dementia will experience it. So we need to have a very good behavior management plan in the hospital. But a lot of times also for care stress, it's too much for them to handle. In a nursing home, when a resident is starting beating another resident, what happened? They send him to the ED and come to the hospital. Another thing is delirium, because infection can cause delirium, and 48% of patients with dementia, they will have delirium when they come to the hospital. There's a high amount. They're acutely unwell. And again, 10 to 18% of people, all people in the community, when they're unwell, they are most likely to have delirium before they even come to the hospital. So we are treating that. Another thing is depression, especially for Alzheimer's disease. 20% to 30% of them will experience depression symptoms. So that's why they are not eating, they are not drinking, and family have to send them to the hospital. But what we are actually worried is pseudo dementia. Do we know about it? Sometimes when the old people, they don't have social life, they are quite depressed, they end up lost the memory because they don't talk much anymore. Every day looks similar. I don't know today's Tuesday or Thursday if I'm doing the same thing every day. So we are treating them like a dementia, but they are not. It's actually depression. So 3D, they are very similar medical condition. They share the similar features, but they are not the same thing. That's why we need to really be careful when we are giving the diagnosis, when we are providing the care. So this is a PTSD we normally commonly say responsive behavior. We used to call it challenging behavior, it's true, but we want to say responsive because we don't want to label people. Being dementia is really quite like a negative word. We want to make sure we are giving a positive feeling now. So we commonly see patients having hallucinations, they are seeing the dog or spiders, and that's why they are jumping out of bed in the ward. Or they might have like this inhibition. When they are feeling too hot, they just take off their clothes and naked in the ward. You're like, oh my gosh. Or when they want to go toilet, they won't go to the toilet, they'll just pee on the floor. That's why the family find it really hard to help. And that's why we need to have a plan to find out a routine. Another one really common is sundowning. Do you know why sundowning? What's the time we normally see the sundowning happen? Evening?
Yeah, when the sun goes down.
Yes, it's visible, yeah. So in the hospital, it's always happen between 4 to 6. I reckon it's because they are hungry and it's darker and everyone left, so they are bored. They want to have a party. So sundowning is a big challenge in the hospital. So what we do is we ask the morning staff to check the patients before they go. We finish around 3 o'clock. So we make sure they go to talk to the patient, make sure they're not too hot, not too cold, not too hungry. So make sure they're comfortable to prevent sundowning. As I mentioned, all behavior happens for a reason. Like before, Donna mentioned before, when your patient's wandering around, what can we do instead of just follow them and walk around like and special prevent a fall? We actually need to start thinking while they are wandering. Are they looking for the food? Are they hungry? Are they looking for the door and they want to go home? Or maybe they just want to go for smoking, so they needed something help. So we want to encourage people to start talking to them, ask the questions to know what happened. So in order to give a very comprehensive cognitive impairment management, what we do is recognize the symptom first. Is this delirium or dementia or something happening? Okay, seems like something's happening. We're gonna use the good tools on the DHR, digital health record, the computer system, to use the tools to assess it. Then we can implement non-pharmacological interventions first. And when the non-pharmacological interventions are not working, we can always try to give medication, but it needs to be safe. We need to create a safe way and monitor plan to them. I want to introduce to you, this is the system we are using in the Canberra Health Service. We have 3 tools for the patients when they come to the hospital. The first one is delirium and cognitive impairment screening. We give all patients above 16 years old. So it's 18, but we do 16 above now. So whoever is age above 65 years old, or maybe they had a fall and then have a new hip fracture, or they had a surgery in the last 4 weeks, whichever box is ticked means they are high risk of delirium or cognitive impairment. The nurses will do the second assessment called 480. 480 is a very good assessment for delirium plus dementia. They have a score from 0 to 12. If the score is between 1 to 3, means there may be cognitive impairment. But if the score above 4 means they are most likely have delirium, which is acute medical condition, then we will ask doctors to review as soon as possible. Then doctors, medical officers will do confusion assessment method, we say CAN. This is a diagnostic tool to confirm the diagnosis. Because keep handing over, say, this patient is confused, doesn't help us to make a plan. We need to have a proper diagnosis and everyone can work on it, either delirium or dementia or both together. So today, we want to mention about one tool for you, the framework. This one called Pinch Me Kindly is created by New Zealand. So what happens when your patient is confused? Do you think they will pinch you or they will punch you? So we do see a lot of situations happen. So these are the common causes of delirium, but they are also the common triggers of BPSD to make your patient with dementia become more aggressive. So in the hospital as a nurse, we make sure the patient is pain-free. We try to remove those NG tube cannula whenever it's not necessary. We also reposition them to make them feel good or give some Panadol or massage. Infection, we make sure the observation is good. If any infection site, we do the sepsis screen. We make sure that we work with dietitian and speech therapist to ensure the patient is having good support for nutrition. We also make sure there's no constipation. So many times the nursing home send the patient to the hospital because the resident is not coping well with the routine. They just walk around and then like a bash other people. When patient come to the hospital, we find out, oh, bowel not open not day 9. What happened? So ED gave the enema and then sent to the geriatric ward. Bowel opened on day 2 and then back to baseline and then went home on day 3. What happened there? Do we really need a patient to come to the hospital just for enema? It's such a simple thing we can resolve aggression, but sometimes we just miss the point. So constipation is really a big trigger for all people with dementia. And of course, hydration. You want them to drink well, you want to make sure they hydrate well so they have energy to walk around. And we work with the physio for exercise. Sometimes not every patient can be out of bed, but nurses will make sure they sit upright to help their lung expand so they can have a more comfortable feeling. Most important thing is by doing the exercise is actually to help them to have a good sleep as well. We don't want to give medication to help people to sleep. But well, sometimes we just turn down the light and say good night and they will go sleep well, but most of the time they can't because hospital is so noisy. We walk around everywhere. You are sleeping and your neighbor is moving around. How can you sleep? So we do say, yes, you can give some medication, but which medication is the safe one? Before tamoxifen or benzodiazepine, we want people to try melatonin first. It's a safe one. It's no harm to try it. And M for medication is another reason for delirium because polypharmacy. If we keep adding medication, we actually are adding the risk to damage the patient's liver function or kidney function. It's not good for them, especially if they have a dementia. And the last one, environment. As Rachael mentioned, it's always good to keep the sensory aid on. Turn off the lights, make them feel comfortable, give some warm blankets. These are all the good interventions to remove those triggers for those behaviors. And we always need to keep kind. So pinch me kindly. Always keep calm and kind, no matter what they do to you. We need to keep in your mind, there are still nice people, just dementia changing their behavior. And 90% of them feel bad about it. And family feel shocking about those behaviors too. Okay. So I'll just mention about dementia. I think we all know about how many dementia. This is the umbrella term. There are more than 12 types of dementia in the world. These are the most common found in the hospital at the moment, especially Alzheimer's, 70%. But they actually all share the different features. So as a nurses, we also treat them differently. So for patients with Alzheimer's disease, they have a short-term memory issue. So what we do is we repeat a few more times. We write it down, we put a sticker on everywhere to remind them. But for vascular dementia patients, you need to be careful. They actually can still have a good memory. It really depends which area the clot stay in the brain. So we try to just to see which one they have, and then we try to talk to them. Don't lie to them. Because you say, I'll come back to do your one dressing later. You never come back. Vascular patient will be angry, and then next day will be, oh, you say you want to come back, but you didn't come back. While Alzheimer's dementia patient won't remember. They'll say, oh, you again, do you want to come, do whatever? So we try to make sure we are using the different approaches to them. Another one is Lewy body dementia, also similar to the Parkinson's dementia. But Lewy body dementia patients normally have Lewy body in the occipital or parietal lobes, which really affect their vision. So the problem is they won't be able to name the thing properly. For example, once my patient told me like, Ivy, can you please give me the soap? I said, soap? She was sitting in the bed. What do you need the soap for? It's not the shower time. She's like, yeah, I want my soap. My hair is so messy. I need to do my hair. I was like, oh, okay. So I just checked the table. I find a comb. So I passed to her. She was so happy. And she started brushing my hair like, oh yes, this is what I need. Now it looks much better. So you need to be careful with Lewy body dementia. They might say something different. And that's why you provide the wrong things and they got angry. So my suggestion is to provide them whatever on the table you can see. If you find out this is not what they want, then they got angry. Number 4 is frontal temporal. As we remember, frontal is about personality and motor. Temporal is about language, right? Broadcast. So this type of patient can be tricky because they don't really understand what we are saying. And sometimes we also cannot understand what they're saying. And the personality will change a lot, especially like, for example, like I mentioned before, if you want to go to toilet, they might just pee on the floor. If you are providing the care they don't want, instead of like a push you away, they might accidentally punch you, like a really big push. So when I approach these patients, we try to remind the staff, say hi first to see what's the patient's mood today. Do things slowly with safe distance before you just jump into the room and do their ops. Last one is alcohol-related dementia, which is getting more and more. So what happens when we're drinking too much? I think people all know about the hangover system. Next day, you just don't function well. And if you drink so much years, and then your brain will get damaged. And that's what happens. They will contribute to the alcohol-related dementia, younger onset of dementia. So accept pinches me kindly. This pinches kindly is a good tool for medical factors, but there are also other 2 factors can contribute to the BPSD. The first one is psychosocial factors, which is good by providing the activities, make sure they're not isolated from the social life. Another one is environmental factors. And in the hospital, we can do so much is like noise, light, temperature, and sensory aid. But we always try to remind people be careful about the pain. Because the issue with dementia patient is they never say they are in pain. Whenever you ask them, they will say, no, I'm good. No, I don't want a Panadol. But we do find out sometimes before you try any antipsychotics medication, Panadol is actually a very good one. We don't know why, but yeah. So we use a different tool to assess them, like a pain assessment in advanced dementia. We observe them by their facial expression, by their body movement to help them. And that was a good one. So these are other non-pharmacological managements I would like to share today, which was already all mentioned by Donna, Rachael, everyone. So the first thing is always to understand their personal life history, to understand what they like, what they do, what they dislike. You don't want to provide this person a cup of tea when the person is actually the coffee lover. And then you want to give some clock or calendars. But I always remind people, do you need those things to remind the person it's a morning or nighttime? Yeah, it's good. But when you have nothing to help you, what can you do as a person walking to the room? Easy. Just say, hi, good morning. Hi, good evening. Oh, good night. You're helping them to understand the timing as well. And sensory aid is a good thing we want to encourage people to use. Do you know about this? Have you seen this in the ward or somewhere? It's very good sensory aid. The texture can mimic like a pad. So when they're holding it, it's like nice and warm. And for the patient with dementia, when they are pulling out their cannulation, we actually pull it on the hand. So instead of keep pulling out the line, they will just play the little button on the top. And this one can save our cannula for a while. Then we can treat the infection more and they can get better quicker. So these are very good tools. So if you want anything like free from the volunteers, we do work with a GOG. This is a very good organization. I have some flyers today if you are interested. Welcome to share with your team. Another one is the music therapy. We find out the music therapy is a very good strategy to help them to calm the aggressive feeling of agitation as well. And we also work with the NDT team to make sure the patient does have a good movement with physio and reminiscence therapy, as we mentioned, make the room comfortable with a family photo or with the blankets they like to make sure they know this is a good spot they love to stay. And do you know about 27% of old population in Australia, their first language is not English. So we notice this now in the Canberra Health, especially when they're having dementia, they just forget how to speak in English. So we have an interpreter service now. You can call at any time. Everyone can call a number to help the patient to translate. We also make a communication flip cards to help them just point a picture when the family is not there. And always, very important is to validate their feeling. Dementia patients actually know they have dementia. Even they don't know they have dementia, they feel bad when they weigh themselves, when they pull on the bed. No one feels good about that. So the most important thing is always try to validate their feeling, to say, oh, sorry, you don't need to worry about this. We'll clean up for you. Let's do this together. Keep them engaged into the care to make sure they still have a control of their life. It's just so important. And we also want to engage with family because the main care is a big point. Care stress is a big issue in dementia care. So in Canberra Health Service, we already create the different handout for them. This is a sunflower tool. I think you all know about this communication tool developed by New South Wales. It's a very good person-centered strategy to understand what this person like, what's the story behind, so you can pick as a topic to build a relationship with them before you start your therapy. So, a big in summary, what we do now in the hospital is we do assessment to find out whether the person is high risk for delirium or dementia, and then we do the CAN by medical team to confirm the diagnosis. Then we apply the non-pharmacological interventions to help them. If it's not working, we are using medication, but we make sure we start low, go slow. We always start with a low dose, especially for older population. And go slow means you don't want to give second dose too quick. You want to observe a little bit. Even when you are giving medication, we still encourage people to combine with non-pharmacological approaches at the same time. Because as we know, there's no medication is created for behaviors. We don't have medication to treat delirium either. So we really need to keep focused on non-pharmacological. This is a behavior management plan we made. After we talk to a family, to the nursing home, to the patient, we find the trigger first, and then we have a nursing plan. For example, this patient likes to listen to music, like classical music. This person likes to eat with the wooden cutleries because the metal cutlery is too heavy and he doesn't like the feeling. So he won't eat if you give a wrong cutlery. And this person likes to take a note when you are talking to him. So we're going to give extra time when you are talking to them. You don't go rush. We also combine with the medical part. We make sure what kind of medication is working, and we are monitor those medication side effects as well. And this plan will go to the nursing home with them or go home with them to the GP to make sure we are providing consistent care. People don't need to spend another time to re-understand this patient again. So they have a sustainable care. This is the flyers we use for the patient's family nowadays. We have delirium and the one for dementia. We also create these beautiful fact sheets for Allied Health to work together. For example, if a patient is in pain, what can medical team do? Medication assessment, nurses can do the different repositioning, everything. Allied Health can also find a good, for example, they can find a good chair cushion to prevent the pressure injury to make a patient feel more comfortable. So this is also a good resource I'm happy to share with you if anyone is interested. Last one, community support. Thank you, Rachael, already covered everything. So you can go to the DSA. So not every hospital has someone like us to provide a personal behavior management plan. So DSA, you can refer your patient to them. They can make a personalized plan for you. For health professionals like us, we can go to the DTA, Dementia Training Australia, that provide the free modules for you to learn about communication skills, dementia, or person-centered plan. And last one is the SPICE. Welcome to refer your patient to them. They are pretty busy. It's fully booked until March next year, but please try to use this resource to help our patients. It's a really, really good one. So that's my presentation today. Thank you.
Yes, does anyone have any questions for Ivy?